Good afternoon, everyone. It is so nice to be here today. It is an honor, privilege to be here. Thanks, Dr. Azom and organizing committee for inviting me. It's always good to back to my home country. So in next few minutes, I will talk about diagnosis and management of INOCA and MINOCA. It's an evolving area, a lot of unknowns. It's very hard to talk both INOCA and MINOCA in few minutes, but we'll try to summarize. I have no disclosures. So what is INOCA? It's a sign symptoms of ischemia, but no obstructive coronary artery disease. It's highly prevalent, but way underdiagnosed. It increases the hospitalization cost. What is MINOCA? MINOCA is the myocardial infarction with no obstructive coronary disease. When you talk about the INOCA and MINOCA, we have to talk about the coronary microvascular disease or coronary microvascular dysfunction. That would be the main talk today. So if you have an obstructive, non-obstructive disease, and if you have stable symptoms, on the right-hand side, you see that you call INOCA. If you have unstable symptoms and non-obstructive disease, we labeled as MINOCA. But coronary microvascular disease can be present in all four categories, particularly in INOCA and MINOCA. Why we talk about the coronary microvascular disease? Because we know that 5% of the coronary anatomy is macrocirculation and 95% is microcirculation. And when patients come to you with recurrent chest pain, you have a normal angiogram, normal stress test, keep coming back to you. You say, oh, he has a psychiatric problem. So no, he or she may not have a psychiatric problem. We have to diagnose what's going on down the road. So how we diagnose the INOCA? There is an option for non-invasive and there is an option for invasive. Non-invasive PET is the most accurate or most robust information, but still it's not complete. You will only get the information for CFR. You will not get the information of IMR or other part that you need, like a acetylcholine challenge test. So we have invasive approach, that's the most accurate, and we do routinely in the cath lab. In our center, we do every day coronary microvascular disease testing. There are two options. One is Doppler wire method and one is thermodilution method. In our center, we do the thermodilution method. So when we talk about the CMD, we have to know only two specific parameters. One is CFR, coronary flow reserve, and another is IMR, index of microvascular resistance. So basically, IMR is the parameter for microcirculation, and we all know the FFR, IFR is all for epicardial vessel. And CFR gives you like entire vasculature, both macrocirculation and microcirculation. So that's why CFR may not be always accurate for diagnosis of CMD. So how we diagnose the INOCA? So you have to have a presence of sign symptoms of angina, then you have to have objective evidence of ischemia, like you have to have an abnormal EKG or you have to have an abnormal stress test. Without those, you cannot just tell the INOCA. So then you do the angiogram or CT angiogram, you know there is no obstructive disease or non-obstructive disease based on the angiogram visually or based on the FFR, IFR. And then you have to have abnormal CFR or abnormal IMR or abnormal positive acetylcholine test. When you meet all these four criteria, then you diagnosed as INOCA. So this is the money slide. Everything is here. Like if you use the thermodilution technique or if you use the Doppler technique, if your CFR is less than 2.5 and IMR is more than 25, by thermodilution method, you diagnose that you have a CMD. And we do by resting and by adenosine. We'll give you some example and pictures, okay? So these are very easy number to remember, 2 and 2.5 or 25, either 2.5 or multiple of 2.5. So when you do the adenosine and if you get the abnormal CFR or IMR, then we do the acetylcholine challenge test. When you give the acetylcholine, then you look for three parameters. You have to have a more than 90% vasospasm, you have to have EKG changes, and you also have to have ischemic symptom. If you do not have these three, then you don't diagnose as positive acetylcholine challenge test. So just remember this. Without going in details about the procedure, what we do, we put the flow wire in the LED, and then we give 3 cc of room temperature saline every few minutes at rest, and we get the coronary flow. And then we give the adenosine, and we give the 3 cc of normal room temperature saline, and we get the coronary flow. And then after that, we do the acetylcholine challenge test. So this is a very common output. For this, you don't have to remember anything. You don't need to know in details. But here, if you see this blue lines is for the resting blood flow, and yellow line is for the hyperemic blood flow, and they will give you the hyperemic 0.31. This is the mean transit time, and there is a resting mean transit time. Based on this mean transit time, you get all these numbers. And you always look for the FFR, PDPA or IFR is normal. You have to have a normal. Then you see there is a CFR number and there is an IMR number. And that's all you need to know. We don't have enough time to go in details how to calculate, but that's very simple. Then we do the acetylcholine challenge test. You see the acetylcholine, and we give the acetylcholine. There is a diffuse disease in the LAD. But that's not enough. You have to look at the EKG. Baseline EKG on the left side. My right-hand side is the abnormal EKG. You see in lead 1, there is a T inversion, and there is a lead 3, there is a subtle ST elevation. So most of the time, you see the T inversion or ST depression. Acetylcholine challenge test, you have to give low, intermediate, and high dose. Keep giving the acetylcholine. We start in our center with the 20 microgram, then we give the 50, then 100, 150, 200. Some operator give up to 250. I stop at 200. So as you can see, the baseline and low acetylcholine, there is no spasm. When you give the high dose, there is a severe spasm, and after giving the nitroglycerin, it all reverses. And you can see there is a live pictures, and you see the diffuse disease there. And look at these pictures. There is a 2 mirror image, exactly the same view, and we gave the acetylcholine high dose. There is no spasm in the epicardial artery. But look at the EKG. This EKG has a significant multiple ST depression in multiple leads, and patients have chest pain. So what is the difference between that one and this one? That one is the epicardial vasospasm called vasospastic angina. This one called microvascular spasm. And this will dictate how you treat those patients. So this is very important. So this is a microvascular spasm. So these are the endotypes of the microvasculature. You did the angiogram, no obstructive disease, FFR is normal. Then if you have a negative acetylcholine test, if you have a normal CFR, normal IMR, you have non-cardiac chest pain. If you have a negative acetylcholine challenge test, but abnormal CFR or abnormal IMR, you have a microvascular dysfunction or called microvascular angina. On the other hand, if you have a positive acetylcholine challenge test, but it may not be normal and abnormal, other things, but we call epicardial vasospasm or vasospastic angina. And on the very extreme on the right-hand side, you see there is no epicardial vasospasm, there is no abnormality of the CFR or IMR, but sorry, they decreased my time, so I have to just talk about the INOCA. I could not be able to finish my MINOCA because it's supposed to give the 13 minutes. But anyway, so microvascular dysfunction and vasospastic angina. So this output you see here, you can see the FFR is normal. You can see the IMR is 16, CFR is and CFR is 2.8 is normal. This is the normal patient non-cardiac chest pain. So how do you treat the INOCA? There are two goals. One is treat the angina itself, and one is to improve the endovascular function, like endovascular dysfunction. Everybody has to have lifestyle modification, aggressive risk factor management, exercise, cardiac rehab, and everybody should get statin and AS1R because it improves the endovascular function. And you treat the angina with anginal medication. When you treat, there's two buckets. One is the microvascular angina, one is the vasospastic angina. And we'll show you next how to treat. Even 3 years before, I didn't know how to treat this patient. We still have some unknowns, but this is in general. If you have a microvascular angina, based on the endotypes, you give the beta blocker first, and you also add the calcium channel blocker, and all other things are common. If you have a vasospastic angina, you do not give the beta blocker, but you give the calcium channel blocker and add the long-acting nitrate and keep giving the treatment. So microvascular angina, avoid long-acting nitrate. Vasospastic angina, avoid the beta blocker. There are multiple other treatment is on the horizon. You can try if you have a refractory angina after treating the first one. There are a couple of other treatment is ongoing too, but we'll finish with a case that 45-year-old female with history of dyslipidemia have been having exertional and random chest pain for last 1 year. chest pain coming randomly, waking her middle of the night. Sometimes it's resolved spontaneously after half an hour, sometimes it's after nitroglycerin. Stress test is normal, CCTA is normal. So we did the angiogram, and we did the adenosine test with the microvascular dysfunction test, and we give the acetylcholine challenge test. You can see there is a severe vasospasm, and after the nitroglycerin is reversed. So how did we treat this patient? There is a no obstructive disease, and there is a CFR is abnormal in the proximal LAD before and after nitroglycerin. So that patient have exertional chest pain because of vasodilatory problem. And this patient also have the severe vasospasm because he's having random chest pain. So we gave both baseline treatment aspirin, atorvastatin, and losartan, and we also avoided beta blocker because he has both vasospastic angina and microvascular angina. So we treated with diltiazem, nitroglycerin, and amlodipine, and patient is chest pain free for almost 2 years. And thank you for your attention. I will not be able to discuss the Minoka because of the time constraint.